We are now recording. Welcome to Conversations with Calvin, We the Species, and with Linda SLOAN LOCKE. And Linda and I have been talking for months to try to put this together because Linda is very busy. I'm not, so I am so excited to do this. And there's so much to unpack, and there's so much Linda has to say. Quickly, Linda is involved in collaborative, and she's going to tell you all about that. And the collaborative, in part, has been formed because there are 1,824,000 people living in New Jersey who experience contact sexual violence in their lifetime, which is a staggering number. Linda will talk more about that. And this is about sexual and domestic violence, this little bit of an interview primarily. And also part of the numbers, there's 2,144,000 people living in New Jersey who've experienced intimate partner violence at some point in their lifetime. And that's way more than 25% of the population. So it's kind of staggering. Linda has the credentials that you have, getting your BSN and MPH from the University of Michigan, which is Big Ten school, your Midwifery Certificate, and I said that the right way, from SUNY Downstate, and your MSW from Rutgers University with a certificate in violence against women and children. You have a position, Chief of Midwifery at St. Joseph's Hospital, where you've been there for over 25 years. By the way, you're amazing. And I am so honored and thrilled that you were here. So, yeah, I am. I really am. So, Linda, take it away. Introduce yourself, a little bio. Take it away.
Thanks, Calvin. Thanks for having me. So I'm not at St. Joe's anymore. I was at that position for 26 years.
Okay.
I retired from that position in 2012, I think.
Okay.
And so I've been working as a midwife I worked at FQHC in Jersey City, and I've been doing social work as an in-home therapist since then, and doing work with a lot of different organizations around the state promoting maternal health and promoting healthcare for folks in New Jersey. So I started the collaborative, and so the collaborative is called New Jersey Health Cares About Domestic and Sexual Violence. And I started that collaborative because of the statistics and because as working as a midwife for over 40 years, and then, getting the background in social work, I began to see the intersection between the impact that experience of having had domestic or sexual violence had on health, and not just had on health, but had on the way people interacted with the healthcare system, right? So the collaborative was started in 2014. And we now have 14 members in the collaborative, and we have a vision of a New Jersey healthcare culture in which healthcare providers in all settings recognize the prevalence and the health impact of both domestic and sexual violence. And in that environment, trauma-informed care is the norm and the standard of care. And so why did I reach out to healthcare providers? They're already really wonderful organizations, New Jersey NJCEDV, New Jersey Coalition to End Domestic Violence, and NJ CASA, which is New Jersey Coalition Against Sexual Assault. And those organizations are really the organizations that work to address domestic and sexual violence directly. So I really started this collaborative to identify this intersection, right, between domestic violence and sexual violence and health. And because people in New Jersey have an interaction with a healthcare provider at least 3 times a year. So they're going to see healthcare providers. They're going to interact with healthcare providers. And so it gives the healthcare provider a unique opportunity to identify and address violence with their patients to help reduce both immediate and long-term harm and consequences. So that's why I started it.
Okay. I should say that you and I met at Dr. Gloria Bachman's Women's Health Institute at Rutgers Robert Wood Johnson Medical School. We were attending a lunchtime meeting, which I'm on the advisory committee, and that's where you and I met. And you know, it was instant when you had done a presentation. So it was instant chemistry, using a semi-medical term. It was instant chemistry, and that's how we got together from the Women's Health Institute and Dr. Bachman. So I may have touched on it, but I think you need to kind of go over this a little bit in more detail. How prevalent is domestic and sexual violence? What are the numbers? I mean, I kind of touched on it, but.
Well, you know, 1 in 4, yeah, you did touch on it. You talked about the New Jersey numbers. And so 1 in 4 women and 1 in 9 men in the United States will experience some kind of either intimate partner or sexual violence during their lifetime. So it's very prevalent, right? So,
Wow.
And so that's why as healthcare providers, we need to be aware of that, because it's more prevalent than a lot of the other kinds of diseases that we screen for on a routine basis in healthcare. So that's why it's really important. And when we talk about health, you know, we need to understand that health is more than going to the provider's office and getting your blood pressure taken, right? Health is a state of complete physical, mental, and social well-being, not just the absence of disease. So in order to have that complete mental, social, and physical well-being, we need to consider all of the things that impact health. And we know, we talk a lot now in healthcare about the social determinants of health, you know, like where you work, you know, how your environment, you know, like whether you have access to clean water, whether you have adequate housing, whether you have an adequate income, what kind of food you have available to eat. We know all of those things have a huge impact on health. And probably we're beginning to see now that those things, those social determinants of health, have a bigger impact on health than that 15-minute visit in the healthcare provider's office. So it's really important that as healthcare providers, we understand that this is one of those social determinants of health. And the definitions, and, you know, people think about domestic violence, they think about, or intimate partner violence, they think about physical violence, but it is more than that. It's a broader thing. It's a pattern of behaviors that include psychological abuse, sexual violence, stalking, any kind of intimidation or threats, and it's focused on gaining power and control over the victim. And then sexual violence would be, you know, people think about rape, of course, but it's any sexual act that's attempted or committed with another person without their explicit and freely given consent. So those are the kind of broad definitions when we're talking about these two things.
Off topic, it's something that pops into my head because I have, you know, I've been doing some interviews. Part of the problem the screening process, the gaining of information from a patient by a practitioner to it because of the sensitivity of the problem and the domestic violence and the sexual violence are patients not as forthright and forthcoming to tell a practitioner, and is a practitioner, you know, does a practitioner even go through the motions because the numbers are staggering to even inquire? You know what I'm saying? Should it be? Is there a better system?
I do.
Okay. Is there a better?
So you know, like, well, I think what you need to understand that healthcare providers ask a lot of very intimate questions of their patients every day on an everyday basis, right? We're used to asking uncomfortable questions. So I think that there's a
That's
couple of
you.
reasons
That's
why.
you. You're,
Yeah.
but because you're so in tune to
So, so I think you're right in a way, that and that's one of the reasons that we started this collaborative to, like really inform healthcare providers about how often this occurs, and not only how often it occurs, but how it may affect your patient's health and affect why they're coming in to see you today, right? So sometimes healthcare providers do feel overwhelmed. There's a lot of different questions we need to ask folks. And so we developed kind of an acronym of SAFE, which is to screen, assess, facilitate referral, and then educate and empower, to kind of give people a framework to use to begin this conversation. And so there are barriers, obviously, to doing the screening and asking the questions. And there's lots of barriers. There's time. There's discomfort on both sides. There may be discomfort on the part of the provider. There may be discomfort on the part of the patient. Patient may, part of it is trust, especially if you're seeing a provider for the first time. You have to spend some time and establish that trust. So when we talk to providers, we talk about how to ask the questions in a non-threatening and accepting way, and basically kind of saying, and especially now during the pandemic, when we're doing so much of this remotely during telehealth, saying to people, well, there's a lot of people I've found in my practice that have had these experiences. And so I just routinely ask everybody a couple of questions about this. And then not only just asking the question, but then giving information. So not only universal screening, but universal education, because we know that people may not tell you on the first visit, the first time they see you. They may not have established that trust, and they may not feel comfortable sharing that information yet. So you ask them the questions, and even if they say no, you say, well, I give all my patients information about resources. And I found it's helpful to, include resource information about domestic and sexual violence with information about other resources. And especially now in this pandemic, we're doing that more. We're giving people information about mental health care, about, food, about jobs, about income supplements. We're trying to share as much information with folks as we can. So to include domestic and sexual violence resources in all the other resources that we're giving, it kind of reduces the stigma around it and the worry people may have about if they're in that kind of situation where they don't want to take home information that is specific to this particular issue. That you can say, well, I'm giving this to you, even if you can't use it, even if it's not relevant for you. Maybe you have a friend or a family member who might be able to use this information, right? And so that kind of neutralizes any feeling of stigma around that. But you're right, it can be a difficult conversation to have. So I encourage healthcare providers to ask those questions, and most people have questions about this in their electronic medical record that they have to ask, at each visit, and to continue to ask it, because it may be the third visit or the fourth visit that the person finally opens up and gives you that information. And the person may never tell you, but if you've given them information about it, they still may be able to get to the resources.
Okay, heavy stuff. Just to go off topic for a brief minute, just kind of an interlude. So I'll ask you one of my favorite questions to ask. Excluding family or friends, is there somebody living or dead you'd like to spend a day with during this pandemic? Maya Angelou. It's great.
Absolutely. That would be the most fantastic day in the world.
That's just great. Perfect. Okay. Yeah, it's funny. I have a little list in my head of people that I just kind of missed meeting. And, there's a whole list. So of course, I never. Anyway, Dr. King is on that list, but I did get to talk to his niece, Alvita.
Wow,
She actually
that's
called
great.
because I was in a place not too long ago where I could have, where I helped her. And she,
Wow.
yeah, it is a wow. So I never got a chance. He's one of my heroes. These are long spiritual things, but the next best thing was chatting with Alvita. So anyway, I don't know why I jumped into that, but moving along. So I don't know if you necessarily touched on this, but what do healthcare providers need to know about this project and need to know about the whole process?
Well, I think, yeah, we did touch on that.
Okay.
We talked about how important it is and how it's one of the things we routinely screen for depression,
Okay.
right, in healthcare. And we routinely just screen for high blood pressure, diabetes. I mean, this is something that has a prevalence level that's up there with those things, right? So it's just important that we're aware of it, and we're important that we understand the both the mental and physical effects that domestic and sexual violence can have on health. That
was my next question specifically, or I don't know if there are specifics, but how does domestic violence and sexual violence, how does it affect health?
So one of the things is if there's physical violence and especially for women, most of the injuries are to the head and neck, and some of them are by non-fatal strangulation. So survivors will also say, oh, the person choked me. Well, choking is when food gets caught in your windpipe, and strangulation is when somebody puts their hand around your neck. And that can cause a decrease in blood flow to the brain and can cause traumatic brain injury. Head injury can also cause traumatic brain injury. Mm-hmm. And we know, when we think about TBI, traumatic brain injury, what do we think about? We think about concussion. We think about football players, and we think about veterans, right? People who've had experienced TBI or traumatic brain injury and maybe automobile accidents. But the fact is that victims and survivors of domestic violence very often can have traumatic brain injury from the injuries they sustained in an abusive relationship. And those symptoms can look very much like the same symptoms of PTSD or depression. There can also be physiological changes due to traumatic brain injury. So that's one area that we know. As far as for women, for pregnancy, we know that experiencing domestic violence can cause a wide variety of poor outcomes: preterm birth, postpartum depression. So, and unfortunately, domestic violence does not decrease during pregnancy. It may actually escalate and get worse. We know that there's increased risk of problems with mental health, depression, PTSD, panic attacks, attempted or completed suicide. So there are a wide variety of both physical and mental health effects of domestic and sexual violence. When we look at sexual violence, we need to know also that about 20% of all women and about 10% of all men have experienced childhood sexual violence. So that can impact even later in life, with how people relate to the healthcare system. So sometimes people are afraid to go to the doctor, afraid to see their healthcare provider. Certain kinds of checkups and examinations may trigger memories of experiences that they've had. So sometimes healthcare providers will say, oh, this person is non-compliant. I hate that word, but they're not following up on a test that I recommended for them. So if that person has had these experiences in their life, and going through even something like a mammography can be triggering, can evoke these memories about those negative experiences that they've had. And so then can intersect with their health care because it's going to interfere with them maybe obtaining the kind of care that they need to get. So there's a wide variety of direct and indirect effects of having that experience on your health. And I think what's also important when we do the screening and we do the assessment, so we want to screen everyone. We want to assess how, if they're in a safe space now, and we want to assess what the impact of that experience has been on their health. And then I'm not saying that every healthcare provider needs to be an expert in this, right? So that's, I think, what gets people scared sometimes. They're worried sometimes. Well, I don't want to kind of open Pandora's box. I don't want to ask these questions and then what do I do with the answers, right? So in New Jersey, every county has an organization that you can refer to so that people can get help with these issues, right? So there is a system in place. So if you're just going to facilitate that referral, right? You're going to get help, give them the information so that they can get there. And then so it's safe, screen, assess, facilitate, and then educate and empower. And that education and empowering piece is really important too, because we can help people make those connections. They may think that some of the symptoms they're having, oh, I'm just crazy, why am I having these symptoms? But if you can say to them, well, I've seen other people with the kind of experience that you've had, and sometimes these kinds of symptoms can be related to that experience, it helps them understand what's going on in their lives more clearly.
You said something just a couple of minutes ago about a woman being pregnant and undergoing that stress and violence portion. I just read the other day that there was a study done that when women are pregnant and undergo stressful situations, that can actually impair the brain development.
The fetal brain development.
Yeah.
Yes, I saw that too. Mm-hmm.
Yeah, it was like, wow. In other words, and we're even taking this above and in addition to the whole issue of domestic and sexual violence, even things that even a pandemic and the worry over can affect fetal development. So you saw that too. So
yeah. So we're really beginning to understand. We used to think, I've been a midwife for over 40 years. So we used to think, oh, baby is, floating around in its nice little bubble of amniotic fluid and it's all protected from everything and it's all safe. Well, protected and safe from a lot of things, but we're beginning to understand that interaction between the mother's full system, physical and mental health, and that stress releases certain hormones that then can have an impact on how the baby develops and how the baby grows. So yeah, and then we know that, like you've got the stress of the pandemic, you may have this stress, and all these stressors on top of each other, can have a cumulative effect.
So I have in my a little note here about trauma-informed care. Mm-hmm. Can you just briefly chat about that?
So trauma-informed care, as defined by SAMHSA. SAMHSA is the Substance Abuse and Mental Health Services Administration, and they describe first trauma as any experience that an individual has, any event or series of events that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has long-lasting effects on your functioning, your mental, physical, and social and emotional functioning. So trauma-informed care is care that understands that any person that we may see in the healthcare setting may have experienced some kind of trauma, either in their lifetime, or we now know that there's generational trauma, right? There's historical trauma that also can have an effect on folks. And that in order to really take care of people well, we need to be sensitive to the fact that people have experienced trauma and to deliver care in a way that is not going to be re-traumatizing to them, right? And sometimes in healthcare, we feel very pressured for time, and the systems in healthcare, it's not so much the practitioners, but the systems in healthcare are set up to get people through in a certain amount of time and get certain things done. And so systems as well as individuals need to understand that it's really important to take this into account when we're caring for people. And that unless we do that, we're not really going to be able to meet their needs in the best way possible.
Well, that's heavy stuff. So, next to last question, any takeaway messages that you want to deliver?
I guess the takeaway message is that you can be the bridge. You know, you as a healthcare provider can be the bridge that helps get somebody to a safe place. You can be the bridge that helps somebody make that connection that some of the symptoms that they're having and some of the health issues that they're having may actually be related to the trauma of their experience of domestic and sexual violence, and then help them to get the help that they need, whether it be mental health care or whether it be maybe they need to see a neurologist for the symptoms that they're having that are related to traumatic brain injury, right? So, but unless you ask that question, unless you find that information out, unless you do that screening or give that education, you're missing that. So you can be that bridge, that really essential bridge to really help folks get the help that they need. And the other take-home message is that we think about this as a woman's issue, and it's not just a woman's issue. We know that this is an issue that exists for men, that exists for elderly people. Elder abuse is a real thing as well. So that it's something that occurs in every race and ethnicity, and every income level, and it occurs across the lifespan.
Heavy stuff. This has been great. And I think an appropriate question to kind of wind this down. It's been more than great. For me, totally illuminating, even the numbers, because I don't think there's anybody out there that even has the slightest grasp of the depth and the breadth of the problem. Not only here in New Jersey, but across the whole country. It's my goodness. This kind of reminds me of a TV show. It's not Candid Camera, but there was a TV show from the 50s. But so I'm kind of roaming here. Is there anything people would be surprised to know about you, Linda SLOAN LOCKE?
So some people know this, but they might be surprised to know that my dad was a Tuskegee Airman, and so my first experience flying was in a plane with my dad in a little Cessna. And before the pandemic, I was working on getting my pilot's license, so that's still like my dream. I love it up in the air. I just absolutely love being in the air in a little Cessna 172 and flying. It's just a great feeling. It's just a wonderful feeling. So
that's
might not know
great.
that about me.
A Tuskegee Airman. Wow.
Yeah.
The stories I can't even imagine. I don't touch the flying thing. I don't particularly like being off the ground. But you should know, completely off topic, that my first foray into journalism, which was 9 or 10 years ago, my first story, I randomly walked in, and this has to do with you. You'll see where I'm going. My first story, I randomly walked in with a TV camera into an antique store in Asbury Park. They had old 50s and 60s antiques. And the woman behind the counter who I eventually interviewed and became good friends with her, Judy, was one of the first female pilots in New Jersey.
Wow. Great.
And she used to, she taught flying back in the 50s and 60s, and she eventually, she was such a good pilot that she eventually flew Barry Goldwater around when he was running for president. So that was my first journalistic story. Interviewing her was just random, and I was so and I learned so much that it just wasn't female pilots just wasn't kind of accepted back then. So hearing you want to do that, I think is great. So I don't know why I said that, but it's kind of related to you, and this has been so special, and I've waited for this time with you for a long time, and I can't thank you enough for sharing your time, your wonderful time, precious time, for sharing this with us. As people will see, the information how and where people can get in touch is going to be flashed along the screen. And Linda, I just thank you so much for being so gracious.
Thanks again, Calvin, for having me.
Yes.
It was a pleasure.
Yes, and we're going to sign off. And again, thanks, Linda.